The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another issue of the Genuine Article. And today we're going to try to answer the question of whether or not we should give our ACS patients clopidogrel prior to catheterization, knowing full well some of them may go to CABG surgery. And in fact, whether or not we should delay CABG surgery in those patients who come in with ACS already on clopidogrel. And to answer that for us from the Acuity trial is Dr. Ramin Ibrahimi. And Dr. Ibrahimi is Associate Professor of Medicine at the Greater Los Angeles VA Medical Center and at UCLA. So Ramin, tell us a little bit about the analysis you did from the Acuity trial.
This was a sub-analysis of the Acuity trial that looked at moderate to high-risk patients who were admitted for acute coronary syndrome. And of the over 13,800, about 1,500 patients, 1,539 patients ended up in bypass surgery. In this trial, the clopidogrel use was left at the discretion of the physicians, and it allowed us to look at the practice of giving or not giving clopidogrel before CABG.
Wonderful database. So as I recall, you had about 700 patients who received clopidogrel prior to CABG and about an equal number who did not.
That's correct. Almost 50% got clopidogrel before CABG and 50% did not.
And what endpoints were you looking at?
We looked at ischemic endpoints, the standard ischemic endpoints of death, myocardial infarction, and need for urgent revascularization, as well as a bleeding endpoint, which was a primary endpoint from Acuity. So it truly allowed us to look at bleeding problems with these patients.
Good. And what did you find? Did the patients who went to CABG having received clopidogrel have more ischemic events or more bleeding?
Interestingly enough, what we found is that giving clopidogrel actually is an independent predictor of a lower ischemic outcome. They had significantly lower ischemic outcome, most of which was decrease in myocardial infarction. And by the same token, when we looked at the bleeding outcomes, there was no significant increase in non-CABG major bleeding or post-CABG major bleeding.
Now, I assume most of the patients who got clopidogrel were held for 5 days. Is that correct?
That was our recommendation based on ACC/AHA guidelines. Interestingly enough, about 68% of these patients ended up going to CABG prior to the recommended 5 days. And this deviation from the guidelines is not new. The previous data set published based on Dr. Maida's data from Crusade, which was published in 2006 in JACC, showed the same thing, that almost 80 to 90% of these patients do not wait 5 days to go to CABG.
So this is really unexpected, at least to me in my practice. The patients who received clopidogrel prior to CABG surgery had less ischemic events and no additional bleeding events. Am I correct about that?
That's correct. No increase. Now, one of the limitations was that the intra-op bleeding complications were not specifically looked at, but again, that is not uncommon in some of the previous trials that have done this analysis.
Well, with those data, have you changed your practice now? Do you give all patients with ACS clopidogrel prior to angiography, or are you delaying surgery in those patients?
I think the data strengthens the evidence for usage of dual or antiplatelet therapy in patients with acute coronary syndrome. And it certainly gives us a little bit more confidence in terms of using an agent such as clopidogrel without worrying about the bleeding complications.
Well, I guess we could say that the ideal course of action is to give clopidogrel, and then if the patient needs surgery, to wait 5 days. And by doing this, we'll reduce ischemic events and, in fact, have no additional bleeding risk. But if we have to operate earlier, it's very encouraging that the data seem to support that clopidogrel is not an absolute contraindication to surgery prior to 5 days. For the Genuine Article, I'm Tony DeMaria.